today we'll be discussing about the surgical landmarks of the facial nerve. I'll be discussing about the surgical landmarks during medullary and mastoid surgery and also parotidectomy. If you are new to facial nerve, please watch my previous video, basic neuroanatomy of facial nerve, and then you can watch this as a second video. Knowing the landmarks of facial nerve helps you navigate mastoid surgery and medullary surgery with ease. For most new surgeons and residents, facial nerve is a nightmare, or we fear the facial nerve. I also used to fear the facial nerve, same like I used to fear the city when I moved here 10 years ago. It is like that only. When you move to a town or a city, first time you won't know any roads, any landmarks. You don't know where you are going, how much time it will take to reach and everything. But once you get familiarized with it, once you go through the same route again and again, you will know the timing of the traffic, which are the other routes that you can take to reach the destination easier. Same as with facial nerve. So you have to keep on revising the anatomy and keep on doing surgeries, keep on seeing the facial nerve on table. You will be able to navigate the surgery better. Also, another important thing that you have to remember is when we say the relations of the facial nerve, it is in the anatomical position. What is the anatomical position? A man standing like this. You have learned first year in anatomy. And you should have a 3D imagination of the facial nerve, because on table, patient is not in the anatomical position. Patient is lying down, head is turned to the opposite side, and you are operating like this. So you should have a 3D picture of the facial nerve so that you are able to apply the anatomy in any position the patient is. So stories are over. Let's go into the topic. Coming to the tympanic segment, at the level of the geniculate ganglion, the facial nerve takes a sharp turn and forms the first genu and continues as the tympanic segment. So the tympanic segment runs the entire length of the medial wall of the middle ear, usually at the superior edge. And also we know that in all the pictures and images that you see, it is not like a straight line. The horizontal segment is not like a straight line. It takes a slight inclination from the first genu to the second genu. It takes a slight inclination downwards and laterally it moves. What is the first landmark? First landmark is processus cochleariformis. It is a small projection that acts as a pulley to the tendon of the tensor tympani. So the processus cochleariformis is a constant landmark. Even when other landmarks are eroded or obscured by disease or pathology, processus cochleariformis can be identified. The tympanic segment passes above and medial to the processus cochleariformis. It also is a landmark for the geniculate ganglion and the first genu. Then the nerve continues in the medulla distally, superiorly over the oval window niche. So the nerve is present above the oval window, just anterior and inferior to the lateral semicircular canal or the horizontal semicircular canal. When you see the picture of the middle ear, that is, you have opened the tympanic membrane and you are looking in the middle ear, that is what you see. The tympanic segment is coming, the oval window is here, and the lateral semicircular canal is here. So the nerve will be going like this. That is what you see. The tympanic segment is most common place for dehiscence of the facial canal. That is, a bony canal can be dehiscent, so the nerve can be exposed. Different types of bony dehiscence is there. I explained about it in surgery of otosclerosis. I will show an image here. So there can be dehiscence at different levels. It can make the facial nerve to injury during the staple surgery and also other medullary surgeries. Another constant landmark is the lateral semicircular canal. The second genu hugs the inferior aspect of the lateral semicircular canal. It runs infralaterally to the lateral semicircular canal and continues as the vertical segment. Next landmark is the pyramidal eminence. The pyramidal eminence gives attachment to the stapedius muscle. It is present in the posterior wall of the middle ear. And pyramidal eminence marks the second genu of the facial nerve. At the level of the pyramidal eminence, facial nerve takes a second turn, or the external genu or the second genu. All this is same. And it continues as the vertical segment. It runs behind the pyramid and the posterior tympanic sulcus. And posterior to the second genu, you have the posterior semicircular canal. The posterior semicircular canal also marks the retrofacial air cells, which can be identified to identify the medial part of the facial canal. And the retrotympanic contains so many sinuses around the facial nerve. You can learn that in endoscopic anatomy of the middle ear. And the superior retrotympanic is divided into 4 spaces by the facial canal. So the sinus tympani is anterior and medial to the facial canal. The facial and the posterior tympanic sinus is posterior and lateral to the facial canal. Just keep this in mind. This discussion is for another time. At the second genu and vertical segment is posterolateral to sinus tympani. That is, sinus tympani is anteromedial to the facial nerve. Just keep this in mind. What is facial recess? Facial recess is an aerated extension of the posterior part of the medullary cavity. It is medial to the tympanic membrane because it has to be inside the tympanic membrane, and it is lateral to the facial nerve. So facial nerve forms the medial boundary of facial recess. That is why it is known as facial recess. What is facial recess approach? Facial recess approach is also known as posterior tympanotomy. It is most commonly done in your cochlear implantation. That is, we are approaching the medullary from behind. From the mastoid area, we are approaching the medullary from behind. That is facial recess approach. Because we are approaching posteriorly, it is known as posterior tympanotomy. So what are the boundaries of the facial recess? As you already know, keep in mind, facial nerve is medial. So the medial boundary is facial nerve, the vertical segment, and the second genu of the facial nerve. Lateral boundary, you have the tympanic membrane, so the tympanic annulus and also the chorda tympani. So the chorda tympani will always be medial to the tympanic membrane. So the chorda tympani, in some textbooks says chorda tympani is the lateral boundary. Tympanic annulus and chorda tympani together forms the lateral boundary of the facial recess. What is the superior boundary? The superior boundary is incus buttress. So facial nerve, chorda tympani, tympanic annulus, and the incus buttress forms the boundaries of the facial recess. And the tympanic membrane forms the anterior and lateral boundary. So the tympanic membrane forms the anterior wall. So the anterior and lateral boundary is formed by the tympanic membrane. Drilling the area between the facial nerve medially and the annulus laterally in the angle formed by the chorda tympani gives your entry into the medullary. You have to keep that in mind. That is facial recess approach. Now, after the second genu, it has become the vertical segment. So the vertical segment or the mastoid segment, it runs vertically downwards. In the posterior wall of the medullary is the anterior wall of the mastoid. So that is where it runs downwards. An important landmark that points to the lateral and inter aspect of the mastoid segment is a digastric ridge. Digastric ridge is a bony protuberance crossing the mastoid just above or medial to the mastoid tip. It is formed due to the pull from the posterior belly of digastric cell because it is attached there. It is getting pulled and a small elevation is formed. The nerve leaves the mastoid at the anterior edge of the digastric ridge. Digastric ridge is usually seen prominently in well-pneumatized mastoids. A line drawn between the anterior edge of the digastric ridge and tip of the short process of incus gives the direction of the mastoid segment of the facial nerve. And as I have mentioned in the previous video, at the stylomastoid foramen, the facial nerve sheath merges with the muscle sheath of the digastric muscle, and everything has to be removed en bloc to avoid injury to the facial nerve at that area at the exit at the stylomastoid foramen. Another thing that you have to know is the internal acoustic meatus and the stylomastoid foramen are not in the same line. So the facial nerve travels from posteromedially to anterolaterally. So the plane is not the same. It has to take a tortuous course. To come to the facial recess approach, you did a posterior tympanotomy, and if you are extending it inferiorly, just in the same plane, you can directly go and touch on the facial nerve. That you have to keep in mind. Most classical injury that can happen to the facial nerve is during mastoidectomy. You can accidentally drill onto the second genu. That is where it most commonly happens. So the tip is to identify the tegment, and you can easily identify the plane. And also, identification of the tegment helps you identify the location of the antrum. So, failure to locate the tegment, or if there is an overhanging tegment area, you will be drilling more inferiorly, and there can be chance to injury to the facial nerve. So, the landmarks to summarize are processes cochleariformis, then genital ganglion in first genu is anterior, then you have the oval window, the nerve is above, then you have the short process of incus, the nerve is medial. The lateral semicircular canal or the horizontal semicircular canal, the nerve is antero-inferior or below the lateral semicircular canal. Then comes the pyramidal eminence, the nerve is posterior to the pyramidal eminence. Then the digastric ridge. The digastric ridge, the nerve is at the anterior end of the digastric ridge. Then the tympanomastoid suture line, the nerve lands behind the tympanomastoid suture line. These are all the landmarks for the medullary and mastoid surgery. Coming to parotid surgery, what are the landmarks for parotid surgery? The nerve exits the stylomastoid foramen and it enters the parotid gland higher up in the posteromedial surface. The nerve passes forwards and downwards behind the mandibular ramus and in the substance of the parotid, just behind and superficial to the retromandibular vein, the nerve divides into two trunks, temporofacial and cervicofacial. So what are the landmarks for the parotid surgery. The first one is the tragal pointer. The tragal pointer is a medial aspect of the tragus which points inwards, forming the anterior and inferior wall of the external auditory meatus. The problem with this is it's a soft tissue and there can be some minor changes. It cannot be completely reliable. The facial nerve lies 1 centimeter medial and inferior to the tragal pointer. The next landmark is you can identify the posterior belly of digastric. The nerve runs superficially and parallel to the posterior belly of digastric, or by retrograde dissection along the posterior belly of digastric to its attachment to the mastoid tip, you can identify the nerve. The main trunk bisects the angle between the upper border of the digastric muscle and the external auditory meatus. Then the junction between the cartilaginous and bony external auditory canal. The nerve was found deep to the midpoint between a line joined between the bony cartilaginous section of external auditory canal and the mastoid tip. Another landmark is temporal-mastoid suture. Temporal-mastoid suture is found to be a very reliable landmark. The nerve runs deep to the temporal-mastoid suture. The trunk can be identified 6 to 8 millimeter below the inferior drop of the temporal-mastoid suture. Another landmark is the transverse process of the axis vertebrae. The transverse process of the axis vertebrae points to where the nerve exits the stylomastoid foramen. That is also a reliable landmark, especially in cancer surgeries where the normal anatomy of the gland can be distorted. Another landmark is the styloid process. The nerve runs lateral to the styloid process. Hence, to summarize the landmarks for the parotid surgery are the tragal pointer, temporal-mastoid suture line, which is a reliable landmark, transverse process of the axis vertebrae, a reliable landmark, the posterior belly of digastric muscle, and the styloid process. You have to keep on revising, have a 3D image. Hope this helps. Thank you.